Hello, this video, this PowerPoint presentation, is part of a series, what we at Kibler Scapular Sessions are calling Greatest Hits. These are PowerPoint presentations that we've made at meetings, and people have asked for them in the past, and so we thought we'd put them on the website so you'd have access to them as a presentation to try to help your understanding and knowledge of the scapula. This first one is called Overview of Scapular Dyskinesis and its Evaluation. So scapular dyskinesis is basically an observed or measured alteration or disruption of resting scapular position or dynamic sequence scapular motion. Now that can be seen in normal asymptomatic individuals. About 53% of the population, if you look at it carefully, will have these, and 61% of overhead athletes without symptoms. So it's not really a clinical diagnosis of an injury or a pathology. It's basically an impairment of the scapular rolls in scapulohumeral rhythm, which then can affect injury or function. It's commonly seen in anywhere from 50 to 100% in subjects with shoulder injuries or symptoms. Whether it's a cause or an effect, we really don't know. Sometimes it can be one or the other. It's the mechanical result of an anatomic injury and alteration in muscle activation or function. It can have multiple causative factors. This is the picture of what we normally see as in resting scapular position. You can obviously see that on clinical examination with the ability to see the back, the medial scapular border prominence with frequently inferior medial border prominence and superior scapular elevation. So the scapula kind of laterally tilts into what we call protraction. Now in dynamic motion, you can see this even better. You will see altered scapular motion with loss of inferior medial border control, with medial border prominence, and loss of upward rotation. It can be seen very well in this video of this symptomatic subject. The right side is the dyskinetic side. You can obviously see the prominence of the inferior medial border, but it's really brought out as they elevate the arm, and mainly when they lower the arm, you can see the loss of control because, as we found out from our model, is that that's a lot of load on the deltoid, a lot of load on the arm, causing this dyskinesis to occur. So now why is this clinical exam finding important? Well, it's because it's an impairment of the two roles of the scapula in these mechanical systems for effective overhead motion. And also it helps us to understand how these motions can be evaluated clinically. The first mechanism is the shoulder girdle. The scapula has to move in such a motion and position so that the arm can be placed in the correct position to do whatever it's supposed to do, throwing a ball, catching a ball, lifting, whatever it happens to be. And it actually moves in three-dimensional space. That's very interesting that if you don't have scapular motion, then as you can see from this picture right here, the light color shows how far you can abduct the arm without scapular motion and how far you can abduct the arm with scapular motion. Similarly, what you can do with horizontal adduction across the body. So it's very important that the scapula has the mobility to place the arm in the right position. Now, once that occurs, then the scapulohumeral mechanism then allows as your arm moves to throw the ball, lift, carry, whatever it has to do, the scapula moves in conjunction with the arm to maintain the concavity compression or the stability, the dynamic stability of the glenohumeral joint. So therefore you can see the scapula is a central segment in both of these mechanisms. In the shoulder girdle, it is the mobility, and in the scapulohumeral mechanism, it's the dynamic stability to allow that function to occur. It's similar to, you can see on the left here, the scapula has to move in the right position, and then of course you see this all the time. You've heard this before, the ball in the sea lion's nose. The ball is moving, but what's really moving to make it work is the sea lion, which is the scapula. Now we've developed a model that we can kind of understand the dynamics of this. You can see on the left, it's basically a scapula with all the muscle attachments and all the bony attachments. On the right, you can see it takes a lot of people to make this model work because there's so many muscles doing so many things around the scapula to make this work right. This is a video, a little snippet of a video of how this actually works. We can look at the bony muscle attachments. We can look at the muscle origins and insertions. We can actually move it and pull on it in different positions to demonstrate how the scapula moves, both in normal activity and also what happens in the altered activity we call dyskinesis. Now, if you look at the causative factors for dyskinesis, the alterations in the anatomy, the pathoanatomy, there's a bunch of them: cervical disc disease, nerve injury, post-traumatic scapular muscle detachment, this thing called snapping scapula, pectoralis minor tightness, fractures of the clavicle or AC joint injury, which is the loss of the strut, or some type of glenohumeral joint injury. So there's some, but that's not very common. The causative factors in what's called physiology, muscle activation, muscle stiffness, tightness, inhibition, there's a bunch of them that are very, very common. Upper trapezius tightness and weakness, lower trapezius weakness, loss of this voluntary control, core weakness, very, very common. Once again, pec minor tightness, altered glenohumeral rotation, latissimus dorsi tightness, serratus anterior weakness or inhibition. Very interesting, something we call SALTI, S-A-L-T-I, is actually a very common coupling of several of these deficits. It's serratus anterior and low trap weakness and inhibition, and lat, pectoralis minor, and upper trap tightness. So what do we do? How do we look at this? How do we evaluate the scapula? Three parts to this. First is that you have to establish the presence or absence of the dyskinesis, both either in a qualitative way or a quantitative way. That'll demonstrate if dyskinesis is present. Second, you have to see whether dyskinesis is actually part of the symptom complex. You do this by what we call using corrective maneuvers, and this affects the clinical presentation, so that tells you how it affects the symptoms. Third is, now we have to assess all these causative factors that I listed. What caused this dyskinesis to be present? So there's a pathway that we can use to kind of go through this in an organized way. First of all, number one, presence or absence of dyskinesis. This is where you do clinical observation. If it's positive, you go to the next step. Negative, then there's something else wrong. Now, it turns out that there's three basic types that are tending to interrelate, but they're actually, we found with the model that they have different reasons for making them appear. Type 1 is an inferior medial border prominence. Type 2 is entire medial border prominence. And type 3 is an upward shrug. Each of them has different ways that the muscles act and don't act to create this. Now, you may see these in each of the motions, but you'll see at a time one is acting more than the other. Now, the test we usually used for confirmation of the presence is called the Scapular Dyskinesis Test. It's a qualitative evaluation. It's the go-to test. It's really to tell you whether the presence or absence is there. You actually have the arm elevate and depress 3 to 5 times, and you watch the medial border. If you see one of the types that we listed, then that's a yes. If you don't, that's a no. And then if you want to, you can go up to 10 reps, add a little weight to put a little bit more stress on there. That will demonstrate whether the scapula is doing what it's supposed to or if it's dyskinetic. This yes-no dyskinesis method has shown a specificity of 0.64, sensitivity of 0.82, and a positive predictive value of 0.84. So it's right up there along with all the other shoulder tests. So it's a good test to use. Now, lately we've been looking at a quantitative measurement of this with a device called a show motion. I am a consultant for a show motion company. Basically, it's an accelerometer, a GPS system, gives real-time data. It's reliable based on biomechanical data relating to bone pins in the scapula, up to 3 to 4 degrees accurate. So it's a very precise method of determining the actual position and motion of the scapula. You can develop normative data and curves out of this. So this is the apparatus. This is a couple of accelerometers that you put on certain positions. And it's very important that you put them exactly where this is, because only in these positions is that data that accurate to 3 to 4 degrees. This is a showing of what this curve looks like with the 3 motions of anterior-posterior tilt, internal external rotation, upward and downward rotation in an asymptomatic individual. Then you can put this along with the normative data that we've developed over a period of time of normal, non-athletic individuals. It turns out using this and using the model, we can demonstrate that there's 4 phases to scapular motion. The first phase is setting of the scapula as you start to raise your arm. Second stage is the maximum scapular motion as the arm goes up toward 90 degrees. Third phase is actually rotation of the clavicle, which then also rotates the scapula. And the fourth is the dynamically stable base that we mentioned to move the arm, to go along with the arm as it is moving. It's type the phase 1, 0 to 30 degrees of abduction or 60 degrees of flexion. The type second phase is 30, 69 degrees up to 100 degrees of elevation or abduction. The third is once again at that above 100 degrees motion where it has to rotate and where it has to be stable as the arm moves. So now if we examine this and we say it is present, does it relate to the symptoms? So we used these two tests, the Scapular Assistance Test, which assists scapular upward rotation and posterior tilt as the arm elevates. A positive test is improvement in the smoothness of motion, relief of external impingement symptoms, or increase in the amount of elevation is going on in the arm. A lot of times the patient will say, hey, that's the way my arm should feel as I'm moving it. It turns out we've done studies that show that actually it really posteriorly tilts the scapula between 5 and 7 degrees. Scapular Retraction Test is stabilizing the scapula with your arm so that you have a stable base. And this positive test here is that you increase your demonstrated rotator cuff strength, or that you change the symptoms of internal impingement where you get the glenoid back into retraction. So if you have these tests that are positive, then you have to, once again, do the evaluation of the causative factors. And as I mentioned, there's a lot of them as listed here, but you can actually go in an exam progression. You can look at the hip and core first, look for scapular muscle detachment, measure scapular and periscapular and shoulder muscle strength, look for muscle tightness by palpation, look for this thing called loss of conscious control, which I'll show you in a minute. You look at your joint exam, glenohumeral joint, AC joint, look for the loss of the function of the clavicle, and then do your neurologic exam. So it's a stepwise progression that you can get all of the problems that may exist. Now we looked at this, all these causative factors, and what we found is that pathoanatomy was about 34%. So only about a third really have something that you can operate on. These would be all these things that we mentioned, the AC joint, glenohumeral joint, neurological fractures, scapular muscle detachment. Non-surgical soft tissue, 65%. About 60% of those are this salty, this coupled combination. The others are combination of upper trap, pectoralis minor, loss of control. About half have something to do with hip and core weakness. So let's go briefly through some of the exam that you would do in this progression. The first is looking at hip and core weakness or instability. What you can do here is look at the deficit with single leg stability. Specific criteria for looking at the motion, and what you can see is have them stand on one leg without tipping. You see that this patient has difficulty even standing on one leg. Then you have them do a half squat and see if they can, and usually you'll see that they lose control with a half squat. This indicates that hip and core is part of the problem. You look at serratus anterior strength. Now really what you're looking for here is the ability of the serratus anterior to hold the scapula back in that phase 1 and phase 2. So you want to see the medial border. You look at this as the key, not how much muscle strength is developed, but how well you actually control the medial border of the scapula. Place the arm in this position. It's a dynamic downward resistance. You can see that she does not control the medial border of the scapula. Similarly, middle and lower trapezius weakness, you do the same thing. You put them in the prone position, downward resistance, and you see, once again, the medial border of the scapula. Does it stay stable? Rhomboids can be measured in the prone position with humerus extended and scapula retracted, and you watch to see stabilized scapula, or in sitting, you resist arm extension. Here's once again the Scapular Assistance Test in video and dynamic. Shows that if you elevate the arm, and there are certain symptoms or loss of motion, stabilize the scapula, and help the assistance of the medial border, they can go higher and smoother. Scapular Retraction Test, you demonstrate strength, then you stabilize the scapula by putting the medial border of the scapula under your forearm. do the same test and find that there's increased strength. You can look at forward flexion strength in do this what's called the empty can scapular retraction, showing that if you stabilize the scapula, strength is improved by about 24%. Another very good test that we use to kind of identify scapular stabilization is called the low row. This is a whole body test where you actually have them place the arm in extension. You push back against them to see if they can stabilize the medial border of the scapula. Then a corrective maneuver is to tighten up the hip, test them again, and usually they can improve their strength by facilitating scapular retraction with hip weakness, showing once again the hip and core deficit. So this salty, serratus anterior weakness or inhibition, lower trapezius weakness, pectoralis minor tightness to palpation, upper trapezius tightness to palpation, latissimus dorsi tightness to palpation, makes up about 67, 2/3 of the pathophysiologic cases. You can estimate scapular protraction with a quantitative test using double square, where you measure from the wall to the anterior coracoid to see bilaterally if there's a difference of more than 1 centimeter, then that's a significant, clinically significant scapular protraction. This loss of voluntary muscle control is something we've been identifying more and more now as a real impediment to therapy and also to improvement. Because what happens here is it's not that they're weak, the muscles are just inhibited. They're not neurologically active. And after about 6 or 8 weeks of scapular or shoulder pain, this phenomenon exists. And if you don't recognize it, then you'll try to do exercises that will not be beneficial. The way you do this is actually have them voluntarily retract the scapula, and you see on the left there, they cannot symmetrically retract their scapula. You have to cue them to show exactly how to retract the scapula in the right direction, usually by having their arms down at the side, using their hip and trunk to facilitate this, and without having arms way out to the side, which then tends to protract the scapula. You have to get that control first before you can actually do any type of exercises up above shoulder level. So in conclusion, the scapular exam is really key to a shoulder injury evaluation. It has to be dynamic. It has to be very specific in its testing to look at these things to find out if the alteration of scapular motion or position is really having anything to do with the shoulder symptoms. There are pathoanatomical and pathophysiological causative deficits for this problem of motion. There's a specific exam pathway that can guide you to rule out the entire breadth of the causative factors. And then you have to correlate those findings with clinical symptoms to make sure that you get the right restoration in your rehabilitation. Thank you very much.